É com muita felicidade que vou ter a oportunidade da gente ter esse Grand Round internacional com o nosso grande amigo que está lá em Los Angeles, Rodrigo Brandt. Rodrigo, obrigado por ter aceito participar aqui com a gente do Grand Round. Então, vamos começar com o caso de vocês inicialmente.
Obrigado, sempre uma honra, né? Acho que daqui para frente agora só em inglês, né?
É.
So
Sim.
let's stop the Portuguese. I'm gonna leave the case now with Wei Cheng. He's our resident. He's a third-year resident. He's gonna present the first case for us. Wei Cheng, all yours.
Thank you, Dr. Brandt, for the introduction. Let me share my slides here. Can everybody see my slides?
Not
No.
yet.
All right. So, hello, everybody. My name is Yicheng Bao. I'm a PGY3 resident here at the USC Roski Eye Institute. The title of my presentation is Old Drug, New Tricks. So this is a patient that we saw at our county hospital here in Los Angeles. It's a 54-year-old female with past medical history of hypertension, fibromyalgia, type 2 diabetes, COPD, and allergic conjunctivitis, who essentially is presenting for blurry vision, difficulty seeing colors, and poor vision at near. She had no past surgical history, no past family history, and then no drugs, alcohol, tobacco. Her best corrected visual acuity was 20/40 in both eyes. Pressures were 19 and 21, pupils were retina reactive, and her EOMs were full. Her slit lamp exam was essentially normal, except for some dry eyes. And then this is her dilated fundus exam.
Nilva, you're gonna
Who wants to
call
talk
someone?
here for me, my resident? Who want to talk? Come.
To describe.
Yes. Vocês acham que é porque em inglês ninguém vai falar? Ok. Arnaldo.
Good evening, everyone. My name is Arnaldo Roisenblatt. I'm a third-year resident. So we see a wide field endoscopy in both eyes. On the right eye, I can see a pink optic disc with sharp margins. I can see no lesions in fovea. I can't see any alterations compatible with the vessels, and attached retina on the right fundus. On the left fundus, though, I can see some pallor and inferior temporal arterial vessel, arterial and venous vessels, but and also kind of more pale up to disc, but sharp margins. For me, I see an unremarkable macula, normal vessels, and only the pallor from the inferior temporal arcade until the periphery of the retina.
Yeah,
Okay.
Great description here. So our attention was drawn to this hemorrhages emanating from the superior arcade here, some vasculitis, and then some pigmentary changes throughout. So we then got a fundus autofluorescence.
Arnaldo, you there? You can continue.
Okay. So on this fundus autofluorescence, I can see on the superior temporal arcade a hypofluorescence and hypofluorescence margin the vessels with a hyperautofluorescence on the borders of those vessels. Also, this hyperfluorescent lesion, I can see bordering the fovea. And I have similar findings on the left eye. I cannot see the hypofluorescence on the temporal arcades, but I can see still the hyperfluorescence surrounding the macula and the optic disc.
Excellent description. We can move on to the OCT macula here. This is just the foveal cut, but then this is the video will play. This is the actual scan with all of the cuts here. So essentially, in this OCT macula, we noted outer retinal atrophy, patchy ellipsoid zone loss, and small pockets of parafoveal intraretinal fluid. With a preserved foveal contour and then some no subretinal fluid, but some vitreous cell as well, and a macular PVD. And then on the left eye, kind of a similar story here. There is parafoveal cystic pockets of cystoid macular edema and some outer retinal atrophy, patchy ellipsoid zone loss, and some vitreous cell as well. So moving on, we transited the right eye with the fluorescein angiography because of the vascular leakage supratemporally. So we noted in the fluorescein angiography patchy choroidal filling, diffuse venular leakage, some disc leakage, and some window defects out in the periphery in the late phases. And similar story here in the left eye as well. So does anybody have any differential diagnoses that they would like to investigate at this point?
So, as we are thinking of vasculitis, we should first rule out all the infections. So, I would ask for serologies for this patient. Also, we need to check for autoinflammatory conditions. And always think of autoimmune or also systemic conditions related to the vessels.
We agree. So that is exactly what we did here. Essentially, a long differential with many infectious inflammatory etiologies that we investigated. So our laboratory workup, the CBC-CMP was normal. The quant gold HIV COVID was negative. She had a positive ANA, but it was relatively low titers. And then the rest of the autoimmune workup, as you astutely suggested, we also ordered, and then we also ordered an RPR as well, and that was positive with titers of 1 to 128, suggesting that this was an ocular syphilis. So after we diagnosed the patient with ocular syphilis, we then referred them to the emergency department for potential admission with IV penicillin. However, the emergency department then consulted the infectious disease department, which noted that the patient had a penicillin allergy. And so the patient could not receive IV penicillin. So then we started the patient on doxycycline 200 milligrams PO daily for 28 days as an alternative to IV penicillin. And then we also obtained a rheumatology consult as well due to the positive ANA titers. And although the ocular syphilis is considered a neurosyphilis equivalent, the current Centers for Disease Control and Prevention guidelines state that a lumbar puncture in cases of isolated ocular syphilis is not needed and does not change management. So we deferred a lumbar puncture. So at the follow-up visit at 2 months, she subjectively noted that the vision was improved although still blurry. Interestingly, her best corrected visual acuity did not improve that much, but she herself was happy with how her vision was improving. And then on the OCT macula, at 2 months, we also noted reconstitution of the ellipsoid zone here, which was very promising for us, showing that her photoreceptors were kind of coming back after that inflammatory insult. Unfortunately, at the follow-up visit at 7 months, her vision decreased in the right eye to 2800, and her fluorescein angiography at that visit showed diffuse capillaritis in both eyes and some petaloid leakage in the right eye as well, and kind of more inflammation than we had seen initially. Interestingly, her RPR came down to 1 to 64, but not more than that, as we were expecting. So then we started this patient on a second course of oral doxycycline, 200 milligrams oral twice a day for another 28 days. Unfortunately, we at this time counseled her on inpatient admission for IV penicillin for a full course, given that she is having more inflammation for secondary to the syphilis now, but she has a fear of inpatient admission. And we are also concerned that she did not fully take the course of doxycycline. And so unfortunately, this patient is considered a treatment failure. And so we also considered doing an intravitreal ceftazidime for local ocular rescue for this patient, given that she doesn't want an IV penicillin. But we are also hoping if any of you had any suggestions for what you would do in this type of situation.
So anyone? I brought this case up because we're basically seeing a syphilis epidemic here. It's really hard to see a toxo case, but we see syphilis patients almost twice a week. And even here, it's really hard to treat those patients as inpatients, like for 14 days with penicillin. So we're basically doing this study here on doxycycline oral because it's so many patients. And I would like to see what you guys think. That's probably something that if it works, is an option, especially in countries where you don't have that many resources. But there's always the question of patient compliance. They have to take all the pills for 8 days, and normally they have other comorbidities. Sometimes they're not very reliable taking all the medication. So this is a downside of it, but it may be a solution, especially in Brazil. When I left here, we're on a shortage of crystalline penicillin. So this is something that can always be thought as an option. Anybody want to comment? Nilva?
I'm asking for Paula from the uveitis sector. Talk to us.
Good evening. My name is Paula Marinho. I am from the uveitis sector. It is interesting to see the use of, first of all, great case, but it's interesting to see the use of doxycycline because it's not on our current practice. We still have the problem sometimes with shortage of penicillin, sometimes with patient compliance. We have found another solution. We're going to talk about it later. But so far, it's, I think the main thing about this case is that we have to think about syphilis as the great masquerade. And you have to think that it's not absolutely, it's not incorrect to say in syphilis, it can be a cross-reaction with some autoimmune disease. So to see a vasculitis presentation and to think about syphilis, but also has some misleading tips regarding autoimmune disease, it's not that unusual. So if you don't pay attention, you're gonna lose the treatment window. So I think the patient was really, really well conducted. But regarding treatment, I think we're going to talk about it a bit more later. I think it's a good discussion to see two different places with the same problem and different solutions. I think it's going to be interesting to put our cards on the table as well.
What do you think about intravitreal treatment?
We don't
With
have-
this drug or another
yeah,
drug?
We don't have that much experience because syphilis is like, in Portuguese, we'd say bread and coffee for us. So it's everyday clinics for us. Like,
And here's bread and butter.
yeah, everyday clinics twice daily. So it's really, really common for us. And we do have a good management follow-up of our patients. Either with penicillin, we use the ceftriaxone, that would be our other choice. And I think we were talking with the residents from Chicago last week. Were they from Chicago? And they were talking, they would have some kind of infusion pump where the patient could do the medication from home with penicillin, so they wouldn't have to have an inpatient admission. So I think that would be an awesome solution, but I don't think that's really practical, especially in public health terms. But the oral treatment, it's not reality for us. And I think that one thing that everybody needs to talk about when they talk about changing drugs for, especially antibiotics, is drug resistance. The USA is having big trouble with drug resistance. Brazil is starting to have it as well. So we need to take care with broader spectrum antibiotics and diseases that are still responding to the easier solutions. We need to think about it as well. I don't think it's just about treatment, it's about the future as well.
Caio, do you want to talk?
Yes, I'm Caio Gattieri, head of the retina service from Escola Paulista. And one of options that Paula said is ceftriaxone intramuscularly for 14 days. I think it's a good option for this patient.
Norma, do you want to talk?
I just wanted to point out that she had allergy to penicillin, so that's a big problem here. Our first choice is not available or possible for her, right?
Yeah. So since I got here, I saw this treatment established here, and I was totally against it. This is the first thing I said, okay, this is not the gold standard. We always use penicillin. But due to the size of the service, and basically like the AHS, the hospital here, the county hospital, basically oversees the entire region. They have a lack of beds for those patients. So after I complained and I talked to the other UVA guys here, basically they started this study. Wei Cheng is going to talk a little bit more how many patients we already had, to see the results of the oral treatment for syphilis, to try to surpass this difficulty that we have here to treat the patient as an inpatient. So Wei Cheng, just speak very briefly about it.
Yeah, very briefly. So this study was done under the mentorship of Dr. Brian Toy here at USC. So we're looking at, is oral doxycycline a reasonable alternative to IV penicillin? And so it's already been established that oral doxycycline is an acceptable regimen for latent syphilis. And there's also studies that have been done that looked at the bioavailability of oral doxycycline in the CSF, which showed 25% bioavailability, but we don't know if what percentage of the CSF bioavailability is actually needed to treat the spirochete. And then there was another study done out of the UK that showed clinical and serologic resolution of neurosyphilis in patients treated with IV penicillin plus or IM penicillin plus oral doxycycline. So when the COVID-19 pandemic occurred and there was a large volume of patients inpatient here at the Los Angeles County Hospital, the infectious disease department was, given that we didn't have enough beds, we wanted to see if we could treat the oral with the syphilis with an oral regimen as an alternative in patients with using a shared decision-making method. And we have found so that the patients with an oral doxycycline compared to the IV penicillin, there are both similar reductions in in improvements in the visual acuity in both groups, as well as similar follow-up time points. And then interestingly, we did note, however, that the RPR titers were significantly lower in the IV penicillin group compared to the oral doxycycline group. So what are the benefits of an oral therapy for ocular syphilis is that the cost of an inpatient admission here in the United States is very, very expensive, up from $5,000 to $10,000 a day. There are many hazards of inpatient admission with nosocomial infections, and then PICC line, which you had mentioned during the discussion, doing home infusions is also potentially dangerous as well, due to we have a high prevalence of IV drug users here, and also the central line associated bloodstream infections can also occur. And PICC lines are also not cheap either because they require sometimes a home health nurse going out and seeing the patient in their home. So I think, currently we have 15 patients now in our study with oral that have been treated with oral doxycycline. And I think that, it's this is an alternative that we need to consider when we're thinking about the costs to the healthcare system. And thank you to my collaborators.
All right, great job, Wei-Cheng. Any questions, any comments?
Thank you. I would like to know if Lou Finamore want to talk something.
Nilva, during the pandemic, we have a good experience with the ceftriaxone treatment, and we are learning that probably it's not inferiorly to the penicillin, but we don't have any experience with the doxycycline, so it's a good idea to try to study this here also. Good presentation. Congrats for the team.
Thank you. Anyone? Okay, let's move on, Rodrigo.
Okay, so now we're going to move to the neuro-off case. Dr. Benjamin Jian will present, and the attending that's overseeing the case is Dr. Kimberly Gokowski. You're there, Ben? I don't think we can hear you, Ben. Probably you're muted.
Sorry about that. Hey guys, thanks for having me. Yeah, thank you for having me. It's a pleasure to be here. Dr. Brandt, thanks for the intro. Yeah, my name is Combis Guillaume, or Benjamin Combis Guillaume. I'm one of the neuro-ophthalmology fellows here. My supervising attending is Dr. Gokowski. She's accompanying me with this talk today. There will be some moments where I'll probe the audience and ask fellow residents to help chime in as we go through this case, but let's move forward. The case is going to be about a 24-year-old African-American female. She presented with blurry vision of the right eye for about a week. She noted headaches, worse when lying down. She also noted back pains, pulsatile tinnitus, an asymmetric smile, otherwise denied transient visual obscurations, no double vision, no pain with eye movements. Significant history was that she did have a choroidal rupture of the right eye. This was 2 years prior, causing kind of chronic low vision due to a macular scar. Otherwise, her meds were treatment of a recent gynecological infection. Otherwise, nothing too significant. Her initial testing showed really low vision in the right eye with a afferent pupillary defect, no color vision in that eye and no brightness in that eye. We don't really have baseline testing on her, though we did know that she did have the chronic scar. It's tough to compare, but These are external photos with our permission. You can appreciate the asymmetry here with a right-sided facial droop. That photo on the right of the screen kind of shows her weak orbicular strength, leading to a little bit of a lag ophthalmos there, but kind of a full facial nerve palsy on the right, essentially. Here's a fundus photo on the right. Maybe someone from the audience can kind of quickly go over some of the findings on this.
Okay.
Hey everyone, my name is Leonardo. I'm a second-year resident. So in the right eye fundoscopy, I can see a blurred optic disc, not well-defined margins. I can see this lesion temporal to the fovea, that a scar previously described, and see I think that's it.
Excellent. Leonardo, thank you. I'm going to stick with you for a little bit. Let's go to the left side. What do you find here?
For the fundoscopy of the left eye, I can also see blurred optic disc with not well-defined margins. I'm not seeing any lesions, and increased vascular tortuosity. And I think that's it.
Excellent, thank you. I think Dr. Gokowski ended up highlighting that there is a bit of a disc hemorrhage going on, peripapillary infratemporal to the disc there. But yeah, pretty high-grade disc edema in both eyes here with what we know is an old macular scar from her choroidal rupture. Visual fields, this was a stim 3 on the left and a stim 5 on the right. So pretty severely restricted fields in both eyes. And Leonardo, let's stick with you for a little bit. Why don't you give me a kind of a broad list of differentials that you would want to think about?
We have a patient, 24-year-old female patient, presenting with blurred vision in both eyes, and in the fundoscopy with both optic disc with edema. So I would first rule out any intracranial hypertension causes. I would thinking of another differential diagnosis, we can think of a tumor lesion and hydrocephaly, maybe pseudo tumor. I think I would start from there.
Yeah, excellent, excellent. And you gave me workup too. When I get cases like these, I like to kind of broaden my differential to different kind of categories. So for her, kind of a quick, dirty way to go through it would be of infiltrative causes of neuropathies, so inflammatory causes, including sarcoid, atypical infections like syphilis, TB, Lyme, those can pretty much do anything. Other slightly unlikely in a young patient, but malignant or neoplastic causes. Compressive, which you brought up, which would definitely be a concern here. One would be IIH or another actual space occupying lesion. There are vascular lesions you really want to think about, namely thromboses of the venous sinuses. It could be hypertensive emergency, or it could be kind of MS or one of the other kind of rare demyelinating conditions like NMO or MOG. The first step, as you said, would be to kind of rule out tumors or other kind of intracranial hypertensive causes. So first looking at an MRI here, I'll go ahead and kind of walk through what I see, but this is a axial cut T1 post contrast. And if you can appreciate, there is some serious globe flattening on both globes. The optic nerves themselves do look distended. No obvious enhancement of the nerves, however, but they do look to have sort of distension of the bilateral nerve sheaths with the flattening. Non-specific, but evidence to suggest that there's high pressure in both of the nerves. Here is sagittal cut right through our cellar region, which is a partially empty cella, consistent with that. And this is another axial cut showing the right cranial nerve 7 on its way to the internal acoustic meatus here. And this is showing kind of asymmetrical enhancement This kind of goes in line with our clinical findings of a right-sided seventh nerve palsy. So there's clearly some sort of inflammatory process going on there. Our next step would be to get the lumbar puncture. Oh, before I do that, this is our MRV. We can kind of go through that. And if you follow, there is some narrowing of the venous sinuses there, but no obvious thrombosis. Here's some narrowing you can appreciate. Yeah. So we did a lumbar puncture, very big opening pressure up to 60. However, the serologies were all within normal limits, as well as the CSF analysis. So given negative MRI for intracranial tumors or other obvious lesions and negative serologies, we were running with a diagnosis of IIH. There is data to suggest that you can have concomitant cranial neuropathies, namely in this case, a seventh nerve palsy. In cases of IIH, they are rare, but they can be seen in high pressure situations. And so, Leonardo, let's stick with you. You're doing great here. In this case,
if it's okay, just to kind of like inspire some type of like feedback and whatnot, maybe we can just go a little bit over the workup and the differential, because whenever you're seeing a patient like this, right? Can you go back to your differential diagnosis? There are actually a lot of things I think that go through our mind, right? You see these patients, you hone in on what the chief complaint is, you do a thorough exam, and you do your workup, and you come up with this differential diagnosis, and you realize you really need to complete that workup. And there are a number of things on the exam that fit your most likely hypothesis, and then some things that counter, right? So what do you think? So Kambi, it's like when we think about this, right, we have this female who's obese that comes in complaining of rather suddenish, like subacute vision loss, right? But it's really severe in one eye. It's super asymmetric, right? So initially you're thinking, okay, so she has vision loss. I look at her nerves, they're both swollen, right? But they're both kind of swollen to the same extent, right? And so then that leads you to question, why is it that the vision loss in one eye is so much worse than the other? So anybody maybe from the audience, like, what do you guys think is responsible for that?
Thinking of pseudotumor, I would start first by doing some lifestyle changes for loss of weight. I would start at. Oh, sorry, I was talking about the full treatment.
Yeah.
Yeah, that was another
maybe.
Yeah, I don't think it's so asymmetric. In fact, visual acuity was very worse in the right eye because of the macular scar. So we don't have the visual acuity parameter to base on. Exactly.
So for us, it made things a little complicated. So when this patient was presented to us, I think, okay, the visual acuity is very asymmetric. And mind you, of course, like the way our system works is we get phone calls, but it's not that like we're not always able to actually see as well, right? And so sometimes your trainees are telling you there's a scar in the retina, and you're like, okay, but is that scar fully accountable for this hand motion level of vision loss compared to 20/20, right? And then you're thinking, okay, now this patient also has a relative afferent pupillary defect. So do we usually see that in patients who have IIH? Sorry, I'm still going with the audience.
Luciana Noia is the head of the neuro-ophthalmological sector here.
I see you.
Well, we have. I haven't seen the first slide, but you're affirming you have a pupillary defect in the right eye. The macula is more important in the pupillary reflex. It's one of the most important parts of the reflex, and I think the scar is big enough to make this difference in the.
Yeah, and I agree. It definitely was. I will say that again. I wasn't able to see this scar initially because I didn't see the patient when they first came in. I was at a different hospital while they're working her up, right? But the other thing that comes to my mind when I see a patient like this that has bilateral disc swelling in a young female who has really severe vision loss, and when I start to think about I think what was the third thing on Dr. Guillaume's differential, right? And so I start to worry about demyelinating diseases. I definitely would be very curious to see how many cases of MOG-associated optic neuritis you see on a day-to-day or weekly basis in Brazil. I'll say that for us, it wouldn't be something that wouldn't put like multiple sclerosis highest on my differential for a case like this, right? But then I start to worry about whether or not there's another condition. Can that macular scar completely explain this? I want proof, right? So I want the MRI orbits with contrast. I want proof to show that there isn't enhancement and inflammation to explain this, right? The other thing that's on our list is there's this cranial nerve 7 palsy, right? And so when you look at it and you look at her face, you can see that there's forehead involvement, right? So immediately that tells us that this is peripheral, right? And so you're like, okay, at least if it's peripheral, then I'm not going to think about a central nervous system demyelinating condition, right? But like, how often do you get a cranial nerve 7 palsy from elevated intracranial pressure? Have you guys seen this?
Luciana, Paulo Góes Manso.
So I will say that the cranial nerve 7 palsy definitely also threw us for a little bit of a loop and made us want to kind of step back and second guess, or at least perform, I would say, a thorough workup in order to make sure that we weren't missing anything. And so what you saw was some T2 hypersensitivity in the 7-8 nerve complex there that Dr. Guillaume showed you, which we actually can be associated with patients with elevated intracranial pressure. We think it's probably just a little bit of damage from the stretching that occurs at the brainstem from this kind of pressure. And then we get an opening pressure, a lumbar puncture, which is critical, right? Because we want to make sure that there isn't anything inflammatory, in the CSF that could explain what's any of the things going on. And I will also tell you that we've had a number of cases where patients presented kind of like this, and I assume that they had very severe and urgent onset fulminant IIH, but indeed what we actually end up finding was enhancement of their optic nerves, and they had MOGAD, and those patients also had elevations in intracranial pressure, but a topic for another day. Okay, so should we go, unless there are other questions, we can go back to Dr. Guillaume and talk about treatment.
Let's treat.
Let's treat.
Thank you so much, Dr. Lukowski. That was great. Leonardo, you were kind of walking me through some of the conservative steps that we can take to treat this patient. But taking this case into consideration, kind of the acuity and the high degree of edema with an opening pressure of 60, what do you want to do for her now? And sorry I keep picking on you. You're just doing such a good job.
Okay, so for the management right now, I would start first by oral drugs with acetazolamide.
Excellent.
I'll maybe think of an lumbar puncture, allevium lumbar puncture. I think my first step would be that, and then reevaluate the opening pressure for maybe for the next steps. And for the follow-up, I would, if the pressure reduce, I would continue with the acetazolamide and then start by the lifestyle changes, thinking of weight loss, and would follow up the patient with visual fields and regular follow-up in the clinic.
Beautiful. Thanks, Leonardo. I appreciate you. Strong work. And those are all great options for her. And here at USC, we do have the privilege of having Dr. Glukowski, who is comfortable with optic nerve sheath fenestrations. And I think this is a luxury that not many institutions get to have, but this is a tool we have that we can pull out in these relatively emergent situations. So with her, we did get her started right away on the acetazolamide, kind of quickly titrated her up to 1 gram twice daily. but did not want to delay getting her into the operating room where we can complete our bilateral optic nerve sheath fenestrations. Hope this video works. Yeah, so here we are. That's our optic nerve right behind the globe there on the left. And as Dr. Gokowski approaches it with our needles, she goes ahead and fenestrates the nerve. You can see that sudden gush of CSF. She sort of works to expand that window into the nerve gently. And you can kind of see as that CSF starts to decompress out of the nerve sheath. She uses this nerve hook to further expand our fenestration. And although it looks like our CSF is oily, I think what's happening is it's sort of maybe emulsifying with some of the fat around the nerve, kind of giving that appearance, but that is certainly CSF. Same thing on the other side. You can kind of see that rush of fluid start coming out. Very satisfying moment in the operating room. Great. Okay. So follow-up, this is 1 week afterwards. You can see really impressive resolution so far of our nerves, both sides. And 4 weeks later, essentially flat nerves. So great response to the medicine and the surgical decompression there. Her vision in that right eye with the macular scar did improve dramatically. She went from that hand motion vision, so she was reading the chart at 2100. She still had the APD. So yes, correct. It's likely that that macular scar was causing the APD to begin with. And her seventh nerve palsy also improved as well. This is her preoperative visual field test. And then you can see an improvement. Still severely constricted, though. Good improvement in her central field there. This is our post-op week 1 and post-op week 4 OCT RNFLs. And kind of my attention's drawn to the RNFL thickness maps here. And you can see the dramatic improvement after about a month of surgery. And so kind of the point of this lecture was to point out a few things. One is how sometimes you can get atypical presentations in otherwise complicated patients with complicated ocular histories here. IIH remains high on the differential in these cases, although it should raise your skepticism on what could be going on here. I think management that Leonardo recommended with our MRIs and our lumbar puncture was the way to go and ultimately led us to the diagnosis of IIH. And also to highlight that there are surgical options in these emergent cases of IIH that one should consider. It's particularly in these patients with acute vision changes, a high degree of optic nerve edema, and an otherwise imminent threat to our nerve. So we have options in our institution, which I think we're thankful for. There are other surgical options that we didn't really discuss, like shunting of the CNS. Those are also things we really reach for frequently, but I think every institution does have its sort of kind of protocol for when to do CSF diversion or shunting procedures versus nerve sheath fenestrations. I think my personal opinion would be in the face of imminent vision loss from nerve head edema, you would consider the nerve sheath fenestration versus intractable headaches in the setting of IIH. Maybe we lean towards the shunt diversion, but I'd like to kind of punt this over to Dr. Gokowski kind of for some of her discussion points on kind of treatment options.
Yeah, and I'm also happy to, hear any comments, reactions from the audience. This is one of those kind of examples of a subclass of IH that we call fulminant IH. So these patients tend to present differently. The vast majority, I'm an ophthalmologist, so I'm not a neurologist. The vast majority of patients who present to our clinic have so-called like are referred for disc edema that they were unaware of, right? So incidental findings, or that's what I'm looking for. Incidentally found disc edema. And when you probe them, they say, yeah, I have headaches. Maybe my vision's a little blurry. It's kind of hard, right? But it wasn't something that they thought was an emergency. These patients are different because when they present, they have severe symptoms that come on within the course of 2 to 4 weeks and generally are associated with rapid vision loss, rapid headaches and whatnot. More often than not, these patients will be found to have something like a dural sinus thrombosis. And then interestingly, a study put out of Emory showed that these patients don't tend to have an empty cella. It's basically there wasn't enough time for the CSF to push against the pituitary so that it like freaks out and just gets squished against the cella wall. And in these patients, unfortunately, if the swelling comes on severely and rapidly, they can cause secondary ischemic optic neuropathies, which could be another explanation for the relative apapillary defect that we saw. And then in general, these patients require urgent surgical intervention in order to minimize the chances of permanent vision loss. But love to hear your guys' perspective on cases like this, your experience, please.
Luciana, you're there?
Lu
Paulo?
or Paulo?
I had a problem with that. In this case, we had already a visual field defect, including in the left eye. So when we have a pupillary defect, and also when we have other, usually sixth nerve palsy, but this is indicator of a high pressure, and it's mandatory any kind of surgical procedure. The advantage of nerve sheath fenestration is that you can access the visual loss more specifically. It's not, in this case, she hadn't, I don't remember, but I think she didn't have a complaint of a headache so imminent. And that's the indication of optic nerve fenestration, because it's not so good for the control of the headache. But it's a very nice case and very challenging due to the problem of the scar in the right eye. But the visual field is what gave us.
Any more comments?
That's it. Well, there's a tip, right? Kimberly, I don't think you mentioned yet. If you opt to do the fenestration, you have to leave the intracranial pressure uncontrolled. In that way, the sheath will be like dilated and it's easier to do it, right?
Oh my God,
That's
you
the tip.
totally listen to the things I say. That's amazing.
See, I remember.
Yeah,
I want to pass the tip on.
I will say that, in cases like this, although I love operating, we obviously will give patients a trial on acetazolamide. And I think that this was maybe a little earlier in my career, but I actually I've become even more aggressive, and I'll put patients on 3 grams of acetazolamide a day. And I'll give them a couple days, basically 1 week, to demonstrate to me that they are improving, that their visual fields are improving. And if they haven't demonstrated that, then I will fenestrate them. But I do hold the Diamox the night before because I want the CSF to build up. I want there to be this buffer between the sheath and the nerve so that when I come in, as you can see, it's a little bit of a leap of faith there. Other approaches are people will take forceps. So like we have bayonet forceps. You get in there. It's a small space though. And I was talking to Dr. Guillaume about this, like how many hands it takes to so we put a baseball stitch in, we take the medial rectus off. There are many different approaches. We do that because we're strabismus surgeons. So take the medial rectus off, we put a baseball stitch so that we can pull the eye in extreme abduction. I have someone in the operating room counting for me so that we're not doing that for more than 90 seconds. And then another person has to use Q-tips and a malleable to keep the fat out of the way. And then you're holding. And so I will take a bayonet forceps and try to lift the dura so that I can snip it and actually snip away a window in these patients. But yeah, it's
Thank you very much, Dr. Golkowski and Dr. Brandt. Now we move on to our cases. Thank you.
All right.
Good evening, everyone. So can you see my presentation? Yeah.
Yes.
Okay. Yeah. So good evening, everyone. My name is Henrique Ferrer. I'm a second-year resident here at Escola Paulista. My supervisor in this case was Dr. Paula Marinho. The head of the uveitis division is Dr. Luciana Finamor. And I would like to give here special thanks to Dr. Guilherme Macedo. I have no conflict of interest. And we have a 40-year-old male, non-Caucasian, born and living in São Paulo, who came to our emergency room complaining of a central gray spot in the vision of the right eye for about 2 weeks. He denied any medical, including ophthalmological, nor family history. At his ophthalmological exam, he had a best corrected visual acuity of the right eye of 20/100 and 20/20 in the left eye. His pupillary reflexes were normal, with no afferent pupillary defect. In his anterior slit lamp examination of the right eye, he had a clear conjunctiva, clear cornea. The anterior chamber was formed without anterior chamber reaction, had a trophic iris, transparent lens, and we could visualize some vitreous cells in the right eye. In the left eye, he had a clear conjunctiva, clear cornea. The anterior chamber was formed without anterior chamber reaction, trophic iris, transparent lens, and no vitreous cells. His intraocular pressure was 14 in the right eye and 12 in the left eye. And I'm going to show pictures of the fundoscopy. So now the fundoscopy, do we have residents from the University of Southern California?
Good evening, everyone. My name is Carolina. I'm a second-year resident. So in the fundoscopy of the right eye, we can see a pink obtuse with sharp margins, cup-to-disc ratio of 0.3. Normal vessels, and I can maybe see a white lesion, the macula, and the retina is attached. In the left eye, we can see pink obtuse with sharp margins, cup-to-disc ratio of 0.2, normal vessels and normal macula, and the retina is attached.
Perfect, Carol. So here the vitreous was clear, and we had this white lesion superior to the fovea. And here the periphery of the right eye, we had this small multiple lesions, white and yellow multiple lesions in the periphery of the right eye. So now as differential diagnosis,
About male patient, about 40 years old, with an acute unilateral uveitis, neuromelatosis. We need to think about some different diagnoses like tuberculosis, syphilis, and the megalovirus, F sample, and sarcoidosis. Yes.
yes. So first of all, we have an acute unilateral non-granulomatous posterior uveitis, and we can divide them as possible infectious and non-infectious causes. Thinking about infectious causes, we can think about syphilis, herpes simplex virus, tuberculosis, cytomegalovirus, and non-infections. We can think about acute posterior multifocal placoid pigment epitheliopathy, sarcoidosis, and mask syndrome. So now for the management. We can hear you.
I think we have Brian Toy online.
Sorry?
Brian Toy.
What?
Can you hear me?
Hi, Rodrigo.
Right.
Yeah. Brian Toy is our head of the uveitis sector here. He's here present to try to discuss the cases with you. So, Brian, do you have any thoughts on the case?
No, I think that's very nice case presentation and succinctly describe an acute unilateral posterior uveitis with the posterior placoid findings and also some areas within the retinal periphery with retinal whitening. So I think that differential diagnosis is very very appropriate.
Good evening, everyone. My name is Tulio. I'm a 30-year resident in service. So we have a young patient with infectious main diagnosis of posterior uveitis. So we need to ask for some general exams and also some serologies such as HIV and syphilis, including anthroponemic and non-anthroponemic tests. We also need to order macular OCT in the fundus autofluorescence.
So perfect. So first of all, we ordered some lab exams, serologies, HIV serology, VDRL, FTABS, and thinking about images, we ordered an OCT and macular OCT and a fundus autofluorescence. So here we have the fundus autofluorescence of both eyes. In the right eye, we see that we have this area of hyperfluorescence combined with an area of hypofluorescence. The exam in the left eye was normal. So here we have the macular OCT of the right eye. We see some irregularity in the outer retina, especially here in the ellipsoid zone. Here in this picture, we can better visualize this irregularity in the ellipsoid zone. The exam, the OCT of the left eye was normal. As we can see, all the retinal layers were preserved. And here the picture. So the HIV serology was non-reactive. The VDRL title was 1 to 128. And the FATBS was reactive. So the treatment we did for ocular syphilis in this situation was ceftriaxone 2 grams intravenously once a day for 14 days. Here we have the fundoscopy before the treatment with the visual acuity of 2100 and later, 15 days later after the treatment with the visual acuity of 2040. We see now that this placoid lesion that we saw in before the treatment had a partial improvement, looking at the picture on your right, even though we could still see a placoid lesion. But those small dots, yellow small dots, as we can think about, we are going to talk about this later, but these are the Mucioli dots, which are secondary to treponema infection. They didn't change during the course of the disease during these 14 days. Here the fundus autofluorescence. After the treatment with the evolution of the disease, we could see that that the areas of hyperfluorescence actually were prevalent, comparing before that we had hyperfluorescence and hypofluorescence. Now, after the treatment, after these 14 days, we had more areas of hyperfluorescence. Here, the OCT, after the treatment, we had, we see that this irregularity of the ellipsoid zone remained, but we can see, so here we can see a partial improvement, but still we could see this irregularity. Here are the exams after the treatment of the left eye. They remain normal. And now for next steps, we need what we do here. We would repeat VDRL after 3 months and consider a resolution, a drop of 2 titers after 6 to 9 months. In this particular case, we didn't order the cerebrospinal fluid. We didn't collect it. But in case VDRL is positive in the cerebrospinal fluid or more than 5 cells, we would repeat every 6 months until normalized. So now talking about ocular syphilis, it can occur at any stage of the disease, more common in secondary and latent syphilis. We have a diverse and pleomorphic presentations, which include keratitis, neuritis, vasculitis, and scleritis. As typical manifestations of the posterior segment, we can have this syphilitic placoid chorioretinopathy, vasculitis, neuritis, papillitis, confluent chorioretinopathy, with acute retinal necrosis as a differential diagnosis, and pigmentary pseudoretinosis, and internal punctate. As typical manifestations of the anterior segment, we can have conjunctivitis, episcleritis, keratitis, and cataract. And talking about these yellowish dots in the retina, Professor Cristina Muscioli has been a former head of the uveitis division here in our department. They have published this article talking about this, and these retinal dots were due to perivasculitis secondary to treponema infection. Here, another case of ocular syphilis. We had this papillitis in the left eye combined with the secondary syphilis with this dermatological findings. So the treatment of ocular syphilis, it's interesting that we brought our experience today, especially before the last presentation that you talked about doxycycline. Here, the usual treatment is crystalline penicillin, 18 to 24 million units per day for 10 to 14 days. We have an alternative regimen for adults with protein penicillin. But what we have been doing here is IV ceftriaxone 2 grams per day for 14 days. And we have some articles in the literature that support what we have been doing. This article published in Lancet, ceftriaxone was compared with benzopenicillin in the treatment of neurosyphilis in France. It was a retrospective multicenter study that suggested that ceftriaxone was similarly effective for the treatment for neurosyphilis, even though randomized controlled trials should be done to confirm these results. Here, a Brazilian article talking about 15 patients who were treated with ceftriaxone during the COVID pandemic. All those patients had a decrease in the VDRL titles after the treatment with ceftriaxone. And here, another article showing that intravenous ceftriaxone could be efficient in the treatment of ocular syphilis. And last but not least, this article showing that in patients with neurological symptoms living with HIV, that we should have a less invasive approach in these patients, and considering that ceftriaxone has a good penetration in the central nervous system, that's a treatment that we should also consider. So for take-home messages, we had a patient, a 4-year-old patient who came to our emergency room complaining of low visual acuity in his right eye. He had this placoid lesion in the fundoscopy. We have to think about syphilis. Ceftriaxone is a possible treatment, especially in our situation that we have an unavailability sometimes of crystalline penicillin, but crystalline penicillin remains as the standard treatment. So thank you all for the opportunity. These were my references. Thank you very much for your attention.
Thank you.
All right, so now we have two more options to treat.
Yes, yes. I'm gonna ask for Paula a comment, and then if you, Dr. Troy, wanna talk, I'd like to, please.
May I? Yes. So first of all, I want to congrats Henrique on the case, good presentation. And there is one thing that I would like to invite all of us to discuss about, is that today we came for an international grand round. We talked about syphilis in the retina, we talk about syphilis in ophthalmology, we talk about syphilis in uveitis. I'm waiting for the glaucoma, guys. It can be syphilis if the uveitis is not under control. So I think that, as we say every time at the uveitis sector, we always have to think about syphilis. And I think it's great that we are discussing about treatment, because in my first year at the uveitis department, which was 2017, we were talking about penicillin shortage. we would only have penicillin for pregnant women. All other patients, we were discussing, can we do ceftriaxone? Can we do something else? What should we do? And we are in 2024, 7 years later, and we are still talking about options for syphilis. And the funny thing is that they said they had this problem during the COVID pandemic. We had this problem during the COVID pandemic. So I don't think we were really, really severe about lockdowns, because a few months after COVID, everybody had syphilis at our sector, like our patients. It was a huge increase. I don't know what happened. So we need to take a good look. We need to take a good look on our options. We need to think about cost. We are talking, especially in Brazil, in public health system. It's a huge expense to have a patient admit for treatment. Ceftriaxone is more expensive than penicillin. Yes, it is. But what about the cost for internations? What about the social cost for the patient to be in the hospital, to have, if depending on their age, they're gonna have to have someone with them all the time during their admission. So that's one thing we have to talk about. When you talk about changing drugs, and okay, we're gonna take about doxycycline. How is the compliance? The patient's taking those meds at home, because we are the next step we're going to talk about is the drug resistance. So I think we need to talk more seriously about this, and it's really nice to see that the last couple of years we have been talking more about alternatives for syphilis, but there is a lot of things to be considered. And remember, syphilis is a great masquerade. We're gonna see syphilis, especially when we don't think about it.
Thank you. Dr. Troy, please.
Yeah, thank you, Dr. Ferrer. Very nice case presentation. And I think you highlighted very salient points in terms of the clinical findings. So the posterior placoid outer retinal changes are, very classic for posterior uveitis resulting from syphilis, as well as the yellow dots in the periphery. That was very, very nice. A couple of things that I think are also important to note. In California, Los Angeles, and San Francisco in particular, there's been a huge uptick in patients who have syphilis and HIV co-infection. So I think it's very appropriate that you also checked for HIV. And although this patient did not have it, making sure that they are HIV-infected patients are treated with antiretrovirals as well. And yeah, it was very, very interesting to see, both Dr. Bao's case, Icheng's case, as well as your case of syphilis being treated with in the circumstances of penicillin shortage, and keeping in mind the institutional and systems related effects of requiring a patient to be admitted or to go home with a PICC line. I think we need to agree we need to look for alternative treatment options. I did actually have a patient at the University Hospital recently, just to highlight, there's syphilis not just in our county hospital, but in our university referral center as well, who was treated with, again, 14 days of ceftriaxone. But she came back, a month after completing treatment with new areas of hyperautofluorescence, as well as new areas of outer retinal disorganization within the macula. And so in that patient, actually, I was concerned that she may have failed the ceftriaxone treatment, and we initiated a rescue therapy with oral doxycycline. She was, penicillin allergic and refused to be desensitized. And so after a month of treatment with the oral doxycycline, I just saw her back in clinic. She, unlike Icheng's case, she was compliant with her oral doxycycline for 28 days, and there's been resolution of all of her ocular findings, and her RPR has also dropped. So, I think in carefully selected patients, oral outpatient therapy may be effective. And I think we do need to do more work to, as you said, not just looking retrospectively, but prospectively for alternative treatments for syphilis to be able to evaluate them appropriately. Nice case presentation. Thank you.
Thank you, Dr. Toy.
Just one question. When you guys do the doxycycline, for how long do you extend the treatment? For like minimum and maximum? It's the same 10 to 14s, or do you take a longer period?
Much longer. And it's actually, doxycycline comes in, 50 milligram and 100 milligram tablets, but the dose is 200 milligrams twice a day. So 400 milligrams daily for 28 days. And this is what was studied in the UK at the NHS as an outpatient treatment for neurosyphilis. And so we sort of adopted that here. Icheng also mentioned, potential local ocular rescue therapy with intravitreal ceftazidime. And I think that is an option, but we must always worry about, are we setting up the patient for latent syphilis if we're under treating it? So, as you appropriately pointed out, we need to follow the RPR titer down. And the CDC actually recommends that we look for a 4-fold decrease in the titer by 1 year. I noticed that I don't know if there's just different guidelines, perhaps in Brazil, where you look more closely at 6 months for the 2-fold decrease, or do you also follow the patients out longer for that 4-fold decrease?
We usually require two titers degrees in the first 3 months, but we keep the follow-up for at least 1 year of the patients.
Luciana, do you want to talk? Any comments?
Yes. Henrique, congrats for your presentation. And I'd like to thank Dr. Brian Toy and his team for the sharing with us this knowledge about the doxycycline, because we don't have this experience here in Brazil. And as I told before, maybe you can study more here. And I want to make a question about the CSF. When you indicate the CSF function in your patients, here we are not doing it in neurologic asymptomatic patients. What do you do? And what do you think about this? Because CDC also doesn't indicate the CSF in asymptomatic neurologic patients, even in ophthalmologic syphilis.
Yeah, that's a great question. And it used to be a battle we had to fight with the ID department in order to get patients with ocular syphilis to receive IV penicillin treatment. They would say, "Oh no, it's it's just the eye. It doesn't require penicillin IV for 14 days." And they would just give IM penicillin once or twice and say it's enough. But it was a great win for us when the CDC updated their guidelines to classify ocular syphilis as a type of neurosyphilis. So that now we don't have to, send patients for an LP to see if they have, CSF involvement, because we treat them the same. So the treatment for ocular syphilis is the same as neurosyphilis treatment. And was a great win. We didn't have to fight ID for IV penicillin access when it's available. And now when they're finding that there are good outcomes with ceftriaxone or oral doxycycline in carefully selected patients, we can apply some of those findings, I think, in ocular syphilis.
And another comment is that you all know that syphilis has been always recognized as the great mimicker. It can have multiple clinical patterns of presentation, but this phenotypic presentation that Henrique presented is the typical one. So you have also to think about syphilis in this placoid pattern of presentation. It's a very typical kind of syphilis, and it happens also. It happens mainly in the secondary syphilis, but we have to think that all anterior, posterior, diffuse uveitis, we have also to think about this diagnosis.
Thank you. We have to move on. Thank you. Now the last case of the night from the glaucoma sector.
Just a minute. Can you see my screen?
Yes.
Good evening. My name is Daniel De Boer. I'm a second-year resident. I'll be presenting the glaucoma case of the night. My preceptor was Dr. Andrea, and the head of glaucoma division is Dr. Roberto Vessani. Our case starts with a 31-year-old male physician born and raised in São Paulo, who presented with visual blurry in both eyes for the past week, worse on the right eye, hidden eyes, ophthalmologic history and systemic diseases, and family history of ocular disease. In his ophthalmologic exam, he had the best visual acuity with correction of 20/20 in both eyes, with a cycloplegic refraction of -1.5 in both eyes. His intraocular pressure of the right eye was 35 millimeters of mercury, and in the left eye, 28. I will show photos of the anterior biomicroscopy, of the gonioscopy, and of the fundus exam.
So good evening, everyone. My name is Mateus. I'm a second-year resident here. So in the anterior biomicroscopy of the right eye, we can see a clear conjunctiva, clear cornea, deep anterior chamber, trophic iris, and a phakic patient.
And the patient had no anterior chamber reaction, and he also had pigments in corneal endothelium, but it's hard to see in this image.
So the anterior biomicroscopy of the left eye is almost the same. Clear conjunctiva, clear cornea, deep anterior chamber, and trophic iris, and a phakic patient.
And he did not have a anterior chamber reaction, and he also had pigments in corneal endothelium. So in the gonioscopy.
So in the gonioscopy of the right eye, we can see an open angle until sclerospur. We have also important pigmentation of trabecular meshwork in the 4 quadrants.
And in the left eye?
And in the left eye, it's the same. We have open angle until sclerospur as well. And we have this important pigmentation of the trabecular meshwork.
And there was no synechial and pathological changes in both eyes.
In the fundoscopy of the right eye, we have a pink optic disc with sharp margins, optic disc duration of 0.5, normal vessels, normal macula, and attached retina in the posterior pole.
And here we can see a disc of small size, an alpha of peripapillary atrophy, and a localized nerve fiber layer defect temporal superiorly, but it's difficult to see in the image. And in the right eye, left eye.
In the left eye, it's more difficult to see, but we have a pink optic disc with sharp margins, a cupped disc ratio of 0.3, normal vessels, normal macula, and attached retina.
And here it's possible to see a disc of small size as well, with no alpha peripapillary atrophy and nerve defect on the fiber layer. So the retinal nerve fiber layer OCT was performed, and it's starting with the quality of the exam, considering it was carried out on Cyrus. The sinus strength is good, 7 out of 10 in both eyes. The scan is centered, and there are no segmentation artifacts. So the average thickness of the nerve fiber layer was 75 in the right eye and 86 in the left eye. In the right eye, the retinal nerve fiber layer thickness map, deviation map, and the hours graph showed a reduction of the nerve fiber layer in the temporal superior region and also inferiorly. The temporal superior region is most suspected of glaucomatous damage, and the inferior alteration may not represent glaucomatous damage, as it is well at 6 o'clock and not inferior temporal. And in the left eye, we can also see a reduction of the nerve fiber layer in the temporal superior region. And here I present the ganglion cell layer OCT. It has a sinus strength 8 out of 10 in the right eye and 9 out of 10 in the left eye, and a good segmentation. So the average thickness in the right eye was 74 and in the left eye 81. In the thickness map and the hours graph of the right eye, we can see a reduction of ganglion cell thickness in the temporal superior region. And in the left eye, the exam was normal. So we performed a reliable CT standard visual field 24/2. This was his first visual field exam. And in the right eye, we can see this inferior nasal step defect, which corresponds well to the temporal superior thinning of the nerve fiber layer, showing a good structural and functional correspondence. The glaucoma hemifield test was outside normal limits. And in the left eye, in the pattern deviation map, there are these two inferior spots with reduced sensibility. The glaucoma hemifield test was borderline. So for the diagnostic hypothesis,
so we have a 31-year-old patient with these epithelial pigments in the biomicroscopy. In the fundoscopy, we have asymmetric optic cup. And in the gonioscopy, we have an important pigmentation of trabecular meshwork. And in the glaucomatous examiners, we have an important damage that is classic of glaucoma. So we will think about pigmentary glaucoma due to all these manifestations and all the clinical of the patient.
That's perfect. So individuals with these same findings who do not demonstrate optic nerve damage or visual field loss are classified as having pigment dispersion syndrome. But this patient has pigmentary glaucoma. So for the initial management,
I would like to stop here just to acknowledge the presence of our chairman, Dr. Martin Herr, and the head of the glaucoma sector, Dr. Benjamin Shu, and also Dr. Van Noy, that's here with me in the clinic. They're going to discuss this case as you will. So anybody want to say anything about the management? Ben?
Sure. I can get started here. First of all, this is a very interesting case. It's interesting because there's not a lot of cupping here in the right eye. The RNFL is quite thin, but I do wonder if the IOP had not been elevated, if this patient would have received such a thorough evaluation and had the glaucoma detected. It's certainly very interesting. We can talk about that, and it may be related to the small disc areas. I think in this case, I would start with IOP lowering, as we typically do when the pressure is high. The question is, how would we do that? I think starting with a conversation about drops versus SLT is a good choice in this case. We know that patients with pigment dispersion respond well to SLT because the pigment takes up the laser well. Of course, in the United States, patients often elect to start with drops because it sounds more benign. But I think in this case, a serious conversation should be had about drops versus SLT. It's important to set a goal here as well in terms of pressure. Usually we aim for about a 30% reduction, but here this patient's pressure is quite high, in the mid-30s. And I do wonder if the patient is spiking or is consistently high. In this case, usually patients with PDS will have pressure that goes up and down. And then certainly I would like to get some more imaging as well, if anterior segment imaging is available, just to see the profile of the iris. But I think this is a very interesting case that you presented here.
I believe we have the
So
anterior segment
that-
image, yeah? And
May I continue?
Yep.
Yes.
So that's what we did. We started the patient on a combined eye drop of timolol and dorzolamide twice a day in both eyes, and we ordered a pachymetry and an ultrasound biomicroscopy for additional evaluation. So 1 week later, the intraocular pressure decreased from 35 to 28 in the right eye and from 28 to 23 in the left eye. His pachymetry of the right eye was 620, and in the left eye, 610. So we performed an ultrasound biomicroscopy. So in the right eye, we can observe that the corneal thickness was within the normal limits, the anterior chamber was deep, and the anterior chamber angle was superior to 40 degrees. The iris shows a concave configuration that increases the irido-lenticular contact. And in the first image, we can observe an increase in the irido-lenticular contact because the patient was accommodating. And in the left eye, it's also possible to observe an open angle with the concave configuration of the iris, increasing the iridolenticular contact. In the sixth image, we also can observe an increase in iridolenticular contact due to accommodation. So for the management, laser peripheral iridotomy has been proposed as an alternative treatment to reduce iris concavity and consequently reduce iridolenticular contact and pigment dispersion. And an anterior segment OCT was requested to evaluate the iris configuration after the laser iridotomy. Although the ideal would be to compare with the same exam, we found it interesting to bring this anterior segment OCT to show the iris configuration. So we can observe the flattening of the iris profile in the right and in the left eye. And here, it's also possible to compare the iris configuration before and after iridotomy, showing a reduction in the iris concavity and in the iridolenticular contact. So surprisingly, after iridotomy, the intraocular pressure decreased from 28 to 18 in the right eye and from 23 to 13 in the left eye. Although the patient had a thick cornea, we added bimatoprost to the prescription because he has a pigmentary glaucoma and not a pigment dispersion syndrome. So the mechanism responsible for the pigmentary glaucoma is the presence of a concave iris configuration, which causes rubbing of the posterior iris surface against the anterior lens zonules during physiologic pupil movement. So it leads to a release of pigments granules, and these pigments over time can cause changes in trabecular endothelial cells and collagen beams. So these changes can lead to increased resistance to aqueous outflow with chronic elevation of IOP and leading to a secondary glaucoma. So the first line treatment option for pigmentary glaucoma, which should be initiated early to prevent progression of the disease. IOP lowering medications can be employed, and meiotic therapy may reduce pigment dispersion, but it's not well tolerated in younger patients. A selective laser trabeculoplasty may be performed when medical therapy is insufficient. So it has been reported to yield a 20% reduction in IOP in 85% of the patients at 1 year, with maintenance of the results in only 14% after 2 years. And after the procedure, it may cause increases in IOP. And a laser peripheral iridotomy is an alternative to change the concave iris configuration, especially in patients with pigment dispersion syndrome. The goal is to reduce iris concavity and consequently reduce iridolenticular contact and pigment dispersion. So the iridotomies are good at stopping the underlying process, but the effect on the eye pressure is unclear. And the trabeculectomy is the surgical treatment of choice when medical and laser treatment is not sufficient or unsuccessful. And a long-term management of pigmentary glaucoma is fundamental in order to prevent glaucomatous optic nerve damage and visual loss. Thank you for your attention.
Danielle, can you go back to the visual fields, left eye especially? Dr. Shu?
I can hear you, Ivan. I can hear you.
No?
I can hear. I can hear. Yeah.
Yeah, me too.
We can.
Okay.
Online,
Good
we can
evening.
hear.
Hi, Dr. Shu.
Yes.
We know it's pretty controversial, iridotomy on pigmentary glaucomas, especially when you already have a high IOP and a visual field defect. And what is your how do you manage these cases? I usually choose the case with pigmentary dispersion syndrome before a moderate or advanced glaucoma to perform iridotomies or like prophylactic iridotomies. I'd like to know how do you conduct these cases?
Well, I want to congratulate you. I think the management here was very, very nice, including the anterior segment imaging. The literature is mixed in terms of the benefit of LPI in pigment dispersion syndrome or pigment dispersion glaucoma. And I think the reason there is that these studies have different inclusion criteria. So here you have a patient who clearly has elevated IOP and glaucoma is damaged. In fact, the pressure is even elevated when you're seeing the patient in office, which is not always the case. And I think if you're trying to avoid more invasive surgery at this point, it's pretty clear that an iridotomy is a very safe option to see if the patient will respond. And in this case, the patient clearly responded. And I think you got beautiful imaging here that shows that there is fairly profound reverse pupillary block, which leads you to suspect that the LPI might work. But in some cases where they take milder cases of PDS, where there may not be so much reverse pupillary block, where you just see some endothelial pigment or some pigment in the TM, but the IOP is otherwise normal, those patients may not respond. And so I think we have to be more selective about who we LPI. It's just like if you have a patient with narrow angles, we know that most of those patients will not benefit because they're very mild in severity. Similarly, I think in patients with mild PDS who don't have frequent episodes of ocular hypertension or excessive glaucoma, those patients won't benefit, and then you end up doing too much LPI. But I think here, if the alternative is a trabeculectomy, why not try it?
Yeah, the better indication of laser iridotomy in this case are when the patient don't have glaucoma pigmentary glaucoma. It's better when we have a pigment dispersion syndrome without increase of the IOP and without trabecular damage. But why we did the LPI in that case? Because because it was a glaucoma pigment, but probably in that case, the patients, the eye still have activity pigment dispersion. Why we would conclude that? Because the main complaint of the patient was that he had blurry vision 7 days before he went to the OR. Then he had an increase of the IOP. That's why we did the UBM, because we thought that he had active pigment dispersion. That's why we did LPI in that case. And usually you do the LPI in patients with pigment dispersion syndrome when we do the test of the phenylephrine, 10% phenylephrine, and we have a pigment dispersion with increase of the IOP. But that was the reason why we did the laser in that patient, and because we saw in the UBM that he had posterior concave iris and with increased IOP level. And in that case—
Can you elaborate?
Sorry.
Sorry, go ahead.
I know you can talk, no, sorry.
Oh, can you elaborate a little bit on the phenylephrine testing? Is that a form of provocative testing, like you're trying to get the eye to shed pigment and the pressure to rise?
Well, I didn't understand, sorry. The phenylephrine test?
He wants to know if the test is, you do it to see if the eye releases more pigment when you do the test.
Yeah, that's we have the Gandalf clinical trial, 10-year follow-up that showed that in that patients with high risk of increased IOP after the phenylephrine test would be a good idea to do the LPI. They did the test with the phenylephrine, and then the IOP got higher. And when they did the UBM, they had a increase of the posterior concave of the iris. And when in that patient, the patient that had risk pigment dispersion, they saw that during the LPI, the level of the IOP was the same of the patient that had a low risk increase of IOP after pigment dispersion of the phenylephrine test.
I've never done that.
But it was all patients with pigment dispersion syndrome.
I've never done that, Andrea. Dr. Shu, I've just heard that you also Bob Weyer's former fellow, as I am. Nice to meet you.
He's still recovering from his PTSD from the fellowship.
No, I'm good. I'm 7 years out, so I'm good. No, it's very nice to make your acquaintance. We should get together sometime and reminisce.
Yes.
But I will say that I'm also not familiar with the phenylephrine testing, but that's very interesting. What proportion of patients respond with an IOP spike just to being dilated once?
Andrea, go ahead.
Do
this test.
In the clinical trial, they show that the percentage of the patient that the high risk patients was the same of the low risk patient after the LIP.
And the pressure before and after?
And the pressure go lower. The
lower,
level of the pressure in the high risk patients was the same of the IOP level as the low risk patients. In the Gandolf clinical trial that followed these patients for 10 years.
Can you send the paper to us, Andrea?
Yes, I will send.
That's very interesting.
Yeah, but and later we start to do the LPI even in patients with glaucoma, pigment glaucoma, but it's not usual. In that case, we did the LPI because the patient had blurry vision probably after physical exercising, after accommodation. A good thing that we could do in that patient would measure. We would tell the patient to do physical exercise, and then before doing the physical exercises, we measure the IOP, and after doing the exercise 30 minutes after that, we could measure the IOP and see if we have an IOP spike in that patient.
I think we should put things together here and to emphasize Dr. Schu's points that these patients, I believe that deserve iridotomy are those with high IOP and with the iris configuration, typical iris configuration at the anterior segmental images, OCT or UBM. I think these patients have more success in the treatment with the iridotomy and mild glaucoma, perhaps moderate glaucoma, and of course, advanced glaucoma, the trabecular patchwork is already so bad that it makes almost no difference to perform the iridotomy or not. I'd like your final comments, Dr. Shu.
Yeah, I completely agree with that. I think what we're discussing here are indications for treatment of these types of eyes, right? So we can move towards more of a precision care model rather than just treating all patients who have some pigment in the eye. I like this idea of proactive testing. We run into similar issues in the treatment of narrow angles, which we also treat with LPI, which is that we look for risk factors to distinguish low risk from high risk PACS or early angle closure eyes. And I think more work needs to be done. I do wonder if you have a higher prevalence of PDS in Brazil. I don't know the prevalence of PDS. We have a very diverse population here in the United States. We often see it in our younger male myopic patients. But it's a very interesting disease. I've told people if I wasn't researching angle closure, I'd research PDS because it's very mysterious why the eye does this too, in terms of assuming this reverse pupillary block configuration. And certainly I think more work needs to be done in terms of understanding the pathogenesis of the disease, but certainly in terms of who should be treated and who shouldn't. But I think this is a beautiful case that illustrates you can avoid having to do trabeculectomy or more invasive surgeries just by doing a simple LPI.
Yeah, you're right.
Okay.
Thanks.
Thank you very much.
We don't have a high prevalence here in Brazil as well. and diverse population as well. And we see some cases, couple of cases a year.
Yes, yes.
I might.
All right, that's it.
Okay. Yes, we're done. Rodrigo, I'd like to thank you very much.
Thank you for having me again.
Yes, I have
pleasure,
to
always.
finish the meeting. A wonderful meeting. Thank you, Rodrigo. It's all your team was amazing. Thank you very much. Doutora Norma.
Always welcome home. Come back home.
All right.
It's great
Anytime
to
is-
have staff from other services. And Rodrigo, thank you for
Thank you.
putting it together.
All right.
Thanks for organizing.
Great cases for everybody. So
Thank you, guys. It was
Thank you
good that
very much.
Thank you.
our residents saw that the residents from Brazil, they have to answer. They don't have to do it here. So Brazilian residents have a harder life.
Don't mention that. Don't mention that.
Bom, eu vou encerrar o Grand Round de hoje, convidando todo mundo para o dia 6. A gente está aqui de volta. Obrigada a todo mundo. Obrigado, Rodrigo,
Falou.
Norma, Ivan.
Tchau.
Muito obrigada
Thank
mesmo.
you.
Foi muito legal, Rodrigo. Obrigada.
Falou, gente. Tchau, tchau.
Thank you. Thank you.